Dissociative identity disorder is a mental health condition that is characterized by 2 or more distinct personality traits. And these personalities control their behavior at certain times. And each alter has different preferences, traits, likes and dislikes, reoccurrent gaps of memory, important personal information, and/or traumatic events. The causes are based on a 4-factor model, an absence of restorative experiences during early development, and environmental factors.
I told you!
We all know that people will fake DID, but is it possible to convince yourself that you have it?
Just because DID has been faked doesn't mean they all are fake. And frankly, when lay people claim that it's always fake, they are harming people with actual disorders here. There's enough stigma out there already. We don't need to add to it. Now, can it be faked? Is it faked? Yes. But is it all fake? No.
What are the signs that somebody is faking DID? And our answer has always been the same. Unless you are actually that person, or that person's mental health expert, or a specialist in the field, you're not gonna know.
It's hard because a lot of people who genuinely have the disorder might be able to relate to some of these symptoms. Imitated DID might involve an individual identifying as having DID and wishing to confirm the diagnosis over any other. Dissociative parts are there to justify identity confusion and internal conflict, connecting personal experience through the lens of dissociation, the ability to receive more attention from friends and family from this diagnosis, and the ruling out of DID in diagnosis leads to anger and disappointment. Genuine DID might have amnesia, identity fragmentation, profound depersonalization and derealization, reluctance and ambivalence, whereas imitated DID might have amnesia for unacceptable behavior, obvious switching, eager and exaggerated presentation, dramatic or vague textbook answers, and using professional jargon. It's important to realize that dissociative identity disorder faking claims aren't always true. A lot of systems might just be in denial, which is a very common symptom. It can be an alter or host protecting the system in any way that they know how. Denial may come out of fear or confusion, but it doesn't mean that it's true. Diagnosing complex dissociative disorders such as DID or OSDD is incredibly complicated. Patients often present a lot of avoidance and rarely report the dissociative symptoms spontaneously without direct questioning. Factitious, as opposed to malingered DID, includes a person convincing themselves that they do indeed have dissociative identity disorder. Both malingering and factitious is when a patient intentionally simulates symptoms either for external gains such as financial benefits or justification of one's actions in court, or other forms of gratification such as interest from others, social media, special attention and fascination from followers, likes, etc., sense of community. If you're performative, you get more attention. You get a psychological gain from understanding your own identity, or at least thinking you do, and labeling and identifying your emotions and behaviors. This can create meaning and reduce emptiness. In factitious DID, your motivation for faking it isn't always conscious. Getting a DID diagnosis can provide structure for inner chaos and incomprehensible experiences, and can be associated with hope and the belief that it is real. On the other hand, diagnostic errors often result in inappropriate treatment plans and procedures. This isn't good because there is a number of people growing who self-diagnose due to what they find on the internet. 36 patients were observed who believed that they had DID, but it was ruled out after applying structured clinical interviews from the SCIDD. These clinicians identified differences between genuine DID and imitated DID. They classified their participants into 3 groups. 1, borderline personality disorder, 2, histrionic personality disorder, And 3, persons with severe dissociative symptoms, but not DID. Participants in that study reported similar symptoms to DID patients, including amnesia, but oftentimes only for things like unacceptable behavior or to like seem cute or quirky, or for sympathy. They can also say that they experience depersonalization, derealization, identity confusion, and identity alteration. However, they might present themselves and interact with their therapist in a different way. While DID patients are usually reluctant to talk about their symptoms and experience their intrusions as shameful, people who imitated DID were eager to present their problems, sometimes in an exaggerated way, with an attempt to convince a clinician that they are indeed suffering with DID. A lot of observations were expressed saying that people who imitate DID can often present their history chronologically, using the first person even when they are highly distressed or allegedly presenting an alter personality. And those alters are often comfortable with disclosing information about experiences of abuse. They can talk about the intrusions of dissociative parts, hearing voices, or difficulty controlling emotions, seemingly without shame. Unfortunately, the DSM-5 doesn't offer any explanation or specific guidelines on how to differentiate patients with personality disorders and dissociative disorders by manners in which they report symptoms. From the clinician's perspective, it is also crucial to understand the motives for being diagnosed with DID, and are they disappointed when the diagnosis is disconfirmed? The DSM-5 gives the following criteria for a factitious disorder. A, falsification of physical or psychological signs or symptoms, or induction of injury or disease associated with identified deception. B, the individual presents himself or herself as ill, impaired, or injured. C, deceptive behavior is evident even in the absence of obvious external rewards. D, the behavior is not explained by another mental disorder, such as delusional disorder or another psychotic episode. A factitious disorder can seem asymptomatic, and in order to make a diagnosis of a factitious disorder, it may be necessary for a health professional to look for clues and patterns in behavior that suggest an individual is being misleading. Some behaviors, however, do make factitious disorder a little bit easier to spot. This includes inconsistencies between patient history and medical observation, vague details that seem plausible on the surface but don't hold up any scrutiny, lengthy medical records with multiple admissions to different hospitals, willingness to accept any discomfort and risk for many medical procedures, even surgery, and overdramatic or outlandish presentation of the factitious illness, or hostility when challenged. The diagnostic criteria for factitious disorders are 4 primary criteria. 1, intentional induction or falsification of physical or psychological signs or symptoms. 2, the individual patient presents as ill, impaired, or injured to others. 3, the deceptive behavior persists even in the absence of external incentives or rewards. 4, another mental disorder does not better explain the behavior. Factitious disorders aren't that well understood. A low number of individuals from wide-range backgrounds are successfully diagnosed with the condition. As such, it is difficult to identify causes of factitious disorders with any certainty. Risk behaviors are believed to include childhood trauma, working in the healthcare profession, and suffering from depression or a personality disorder. Other factors may relate to the onset of a factitious disorder, including a desire to be nurtured or to be distanced from life stressors, and enjoyment of having relationships with doctors and other high perceived status. It is suggested that the dynamics of a parent and child relationship may also be a contributing element if these relationships result in a need to be loved or cared for, a desire to deceive, a need for control, a need to master abusive parents, or a need to be hurt or punished. If you have a factitious disorder, it's okay. You're not a bad person. There's nothing wrong with you. You're probably just suffering with underlying mental health issues. Often treating issues around the factitious disorder, such as comorbid conditions, often brings an end to the factitious disorder itself and enables management for the condition. It is also theorized that treating potential underlying causes, such as historical childhood traumas, may produce similar results. Therapies that focus on helping the individual identify and address their own emotional need for attention or care might be suggested. It should be noted, however, that very few individuals with factitious disorders choose to receive psychiatric treatment. However, cognitive Cognitive behavioral therapy might be used to treat method, and family therapy may also be suggested to help those around the individual understand and manage the disorder, which will in turn aid the individual. Medication may also be used to treat symptoms and/or any co-occurring psychiatric disorders, but do not usually treat factitious disorders in itself.